Welcome to this webinar. I'm purely here to introduce Callum and then take the questions at the end. So I'm absolutely delighted to welcome and to introduce Professor Callum Fraser, who's based up in a very wet and windy Scotland by the sounds of things. Callum is going to give a talk entitled Faecal Haemoglobin, Newer Approaches to Screening and Diagnosis of Colorectal Disease. And I think there's no better person to lead this talk and enlighten us. So over to you, Callum. Thank you.
Thank you very much, Sally, and it's a great pleasure to be giving this webinar this afternoon, and I thank EFLM for sponsoring it and Daniel for doing a huge amount of work behind the scenes to make this happen. So as Sally said, this afternoon we're going to talk about fecal hemoglobin and discuss newer approaches to the use of fecal hemoglobin in screening and diagnosis of colorectal disease. So today I'm going to discuss the relatively new FIT-based paradigm for the detection of colorectal disease, where not only do we use fecal immunochemical tests for hemoglobin FIT in screening asymptomatic populations for colorectal cancer, but we also use fecal hemoglobin concentrations as obtained by FIT in triage of patients who present with lower bowel or lower colorectal, lower gastrointestinal symptoms in primary care. And the whole object of using fecal hemoglobin by FIT in both these clinical settings is that we can use FIT to decide who will benefit most from referral to colonoscopy, which in many of our countries is a very scarce resource. So what are we doing with hemoglobin? Well, many important lesions in the gastrointestinal tract do bleed. So the abnormality is bleeding. So we're using FIT to look for blood in the feces, hemoglobin in the feces. And as you all know, hemoglobin is made up of heme moieties and globin moieties. And the traditional guaiac fecal occult blood test is shown here that we will not be discussing any further because it's obsolete in reality. This is based on the peroxidase activity of hemoglobin. But what we are more interested in is fecal immunochemical tests. And fecal immunochemical tests detect intact hemoglobin in the feces and its early degradation products with antibodies, generally polyclonal, and these are antibodies to the globin moiety of the hemoglobin, to epitopes on the globin. FIT have many advantages. Usually one sample only is required in contrast to the traditional test, and these are generally very easy to collect with user-friendly specimen collection devices such as this shown here. Because it uses antibodies specific to hemoglobin, there is no possibility of interferences from dietary constituents such as other meat from other animals and so on. Often people are worried about aspirin and anticoagulants and whether they interfere, but in fact these are beneficial in that these stimulate bleeding from any bleeding lesion in the gut, making for more blood, more hemoglobin in the feces, so FIT are more clinically sensitive when these drugs are taken than when they're not. And generally, they're more specific for lower GI lesions because hemoglobin is degraded as it passes through the gut. And by the time any hemoglobin in the upper GI tract gets into the colorectum, into the colon, then it will have been broken down. So it's a very specific for lower GI lesions and more analytically sensitive, as we'll see, than traditional guaiac fecal occult blood tests. So FIT are now recommended and advocated in most recommendations on asymptomatic population screening for colorectal cancer, and as we'll talk about, in recent guidelines on triage of patients presenting in primary care with lower bowel symptoms. So fecal immunochemical tests, FIT, come in two formats. The first is qualitative, and these are positive-negative tests done with lateral flow on the traditional immunochromatographic test cassettes or strips, as you see here. These have some problems in that the cut-off fecal concentration for further investigation, usually colonoscopy, is set by the manufacturer and not by the user. The cut-off point or threshold is very different from one qualitative FIT to another. And although people think they're easy to use, they aren't actually very easy to use. Reading the lines that appear are very time dependent. If you read too early, you get false negatives. Too late, you get false positives. Very good visual acuity is needed. And even with one manufacturer, there is lot-to-lot variation. And what I'll be talking mainly about is quantitative FIT. And these measure the fecal hemoglobin concentration, most usually by automated immunoturbidimetry, although other techniques such as ELISA and some lateral flow immunochromatography can be used. The major advantage of quantitative FIT, stated very frequently, is that the fecal cutoff used in clinical decision making can be set by the user. Now, quantitative FIT, there are a number of closed analytical systems available, such as these shown here, and the spectrum is growing all the time with new releases. And indeed, there are calibrators and reagents that can use on open clinical chemistry systems. So we get fecal hemoglobin concentration data. Can we use this better in screening and diagnosis? That's what I'm really going to address. So first of all, thinking about these two settings, FIT, asymptomatic, people without symptoms, participants in screening programs, and also in assessment of patients. So FIT provide one test, but in these two really very, very different clinical settings, which have different aims, different target populations, different interpretations of results, different harms and benefits, and very importantly, different fecal hemoglobin cutoffs, which can cause confusion. So let's first of all think about FIT in screening, where we're using FIT to identify in a selected population, an age range selected population, those who are most likely to have colorectal neoplasia and would most likely benefit from colonoscopy. So this is a rule-in test. A positive result means increased risk of cancer and further investigation warranted. A negative result usually means the participant should be given educational material, but then re-invited for subsequent screening, depending upon 1 year or 2 year screening intervals. Depends on the country. Now, why does screening work? Well, quite a long time ago, we and others showed that if you look at fecal hemoglobin concentrations in normal and in minor colorectal diseases such as diverticular disease, hyperplastic polyps, lower risk or non-advanced adenoma, higher risk or advanced adenoma and colorectal cancer, although there's overlap, you can see that the concentration increases. So the fecal hemoglobin concentration is related to disease. And we have looked further in this, and we've shown that the median fecal hemoglobin concentration is much higher in those with cancer than those with no lesions or non-neoplastic minor lesions. Polyp cancers, small ones, have lower concentrations than bigger cancers, more advanced stage cancers. And higher fecal hemoglobin is found in higher risk adenomas, as I mentioned, than lower risk, large compared with small adenoma, and also in adenoma displaying high-grade dysplasia as compared to those with low-grade dysplasia. So the fundamental principle is that fecal hemoglobin is related to the severity of colorectal disease, and as we go from normal through low-risk adenoma to higher-risk adenoma to cancer, the fecal hemoglobin concentration increases. And therefore, it's hardly surprising that when you change the cutoff concentration used in a screening program, as the fecal hemoglobin cutoff is increased, the positivity rate goes down And it would not surprise you to learn that the detection rate of advanced neoplasia, this cancer and higher risk adenoma, it also goes down. Whereas the positive predictive value actually increases because there are fewer false positive results, and the specificity also increases. So sensitivity down, specificity up. And this has been shown really very elegantly in a recent paper from our colleagues in Germany, Hermann Brenner and his group, who published excellent material on colorectal cancer screening. And you can see as the cutoff is increased, the threshold is increased, then the sensitivity falls, specificity rises, and the positive predictive value also rises and then levels off. This also affects interval cancers. These are cancers which arise between screening intervals. A negative screening test result, and then before the next screening is due, cancer is diagnosed. And as you would expect, as the fecal hemoglobin concentration decreases, the number of interval cancers or the proportion of interval cancers decreases, wherein the number of screen detected cancers increases. So low cutoff, greater sensitivity, fewer interval cancers, but of course at the expense of vastly increased numbers of colonoscopies. What we also ought to realise is that fecal hemoglobin is not the same in every group. It, like many measurands we examine in laboratory medicine, is influenced by age and by sex. And here's a study that we did in 3 countries, in Scotland, in Taiwan, and in the Florence district of Italy. And these are men aged 50 to 54, 55 to 59, 60 to 64, and 65 to 69. So in these 4 groups, you can see that the fecal hemoglobin concentration at any level goes up. And it's different in different countries. The interesting thing is it also rises with age in women, but women always have a less concentration of hemoglobin in their feces than men. Men have higher amounts than women. And other factors are important as well. For example, here is deprivation or socioeconomic status, and the least deprived have less fecal hemoglobin than the most deprived. And again, this holds, men are all in Scotland and the countries we've worked with. Here's a wonderful study done in Australia, in Adelaide. Men have higher concentrations than women. The concentration increases with age, and the concentration increases as one becomes more and more deprived. Although there are many fecal immunochemical test analytical systems, these are based mainly on polyclonal antibodies, and they have different reactivities to the heterogeneous mixture of intact hemoglobin and degradation products in the feces. So FIT do not all give the same results. And you can see this in a study from the Netherlands, that this is the positivity rate versus the cutoff, and the positivity rate is rather different using these 2 different analytical systems, particularly at low concentrations. Therefore, we have found that fecal hemoglobin is obviously affected by some colorectal disease, but men have higher fecal hemoglobin than women, older, higher than younger. The countries are very different from one another. Deprivation is important. More deprived people have higher fecal hemoglobin than less deprived. The analytical system certainly can affect the fecal hemoglobin, especially at low concentrations. If we think about screening rounds, then in the prevalent screening rounds, this is much higher than in subsequent incident screening rounds. Analytical factors such as the stability of hemoglobin in the specimen collection devices that also can affect fecal hemoglobin. So because all these factors affect hemoglobin in the feces, what cutoff or cut should we use in their screening programme? Well, we know that men and women are different, so do you think we should have the same cutoff points for men and women? And this elegant showed sensitivity was always higher and specificity always lower in males compared to females at cutoff. However, if one looks at receiver operating characteristics, ROC curves, they were actually quite similar for both sexes, and we could make for the cutoffs, which were different, to achieve equal combinations of sensitivity and specificity by adjusting the cutoffs to make them different for different. Moreover, what we should realise is that fecal haemoglobin independently does predict risk. And here's a study from Taiwan, and who had concentrations less, very, very important, less than the cutoff point applied in the screening programs. When they, for a number of years, the incidence of colorectal cancer was the fecal hemoglobin concentration, even though it was less than the cutoff point. So all of these people had initial fecal hemoglobin concentrations which would warrant colorectal, and yet over time, in each of the groups, there was some cancer detected, and it was dependent upon the fecal hemoglobin concentration. If you're very near the cutoff point, then you're more likely to have incidence than if no fecal hemoglobin detected. And this also been very elegantly recently shown by our colleague Netherlands. So looking at 4 rounds of FIT screening, after 8 years, 4 screening rounds, participants with a base fecal hemoglobin of 8 to 10, remember 10 is the cutoff used in their screening pilot, they had a higher cumulative incidence, quite a lot higher than with undetectable hemoglobin. And indeed, participants with 2 fecal hemoglobins of 8, just under the cutoff, had a 14-fold increase in the risk of advanced neoplasia than people with 2 consecutive results of undetectable fecal hemoglobin. So fecal hemoglobin is certainly an independent indicator of the risk of colorectal cancer. Because we now know that colorectal cancer, fecal hemoglobin is related to risk. Many factors influence the risk of cancer, such as age and sex, family history, smoking, alcohol intake, obesity, waist circumference, and so on. And it may be that risk scoring systems which combine fecal hemoglobin conditions with other factors, other variables which influence risk, may be important. And it may be that risk scoring systems have a role to play in the future. And here's a very simple example from our colleagues in Barcelona who looked at hemoglobin in men and women, young women, older women, young men and older men, and it made a sort of risk indicator that if you're an older man with a high fecal hemoglobin, you're at much higher risk than if you're with a low fecal hemoglobin. So this is just an example of one way to look at risk management. When I've said deprived, I mean people who are socioeconomically deprived, and it's not just a dietary, it's education, housing, the crime in the area, a very complicated factor, but it is socioeconomic status that we call deprivation. So for screening, there are future challenges, in my opinion. Should we continue to use, as everybody more or less does now, one only hemoglobin cutoff based on the colonoscopy resource available? Should we use different hemoglobin cutoff concentrations for the different groups, as we've discussed, for the old and for the young? And more especially, and we could use fecal hemoglobin alone, as our colleagues in Taiwan have elegantly shown, as well as our colleagues in India. Or we could use this more sophisticated score. But we, in the real future, is to treat people as individuals. The so-called changes over time, perhaps changes with other than just over time. So these are difficult to implement, and certainly there's a great opportunity for everyone participating in this webinar to do research in this area. It is now passed to the second use of FIT, assessment of people who present with lower bowel symptoms in primary care. People complaining of such symptoms are very people tell about 10% of presentations in primary care with lower abdominals. How significant colorectal disease is rather rare. And the real problem for our clinical colleagues is that symptoms of colorectal disease over with those in benign and unimportant, in some cases, a focusing bowel disease when we're thinking about opportunistic or higher inflammatory bowel disease. NHS, you can see that over time the number of referrals increased and increases for a variety of reasons. But the number of cancers and inflammatory bowel diseases detected, it stays the same and is actually a very small proportion. And one of the ways that we thought you could look at this is if you think about the rule of 6, an approximation. So 1/6 of the population being referred for colonoscopy in primary care do have significant colorectal disease. 2/6 less significant bowel disease. A half, 3 no abnormality whatsoever. And what's our role using FIT? Our role is to find the one who would benefit most from colonoscopy. The traditional view of the presence of hemoglobin or blood in assessment of the symptomatic is that it just doesn't work. So NICE, the National Institute for Health and Care Excellence, the Scottish Guidelines Network, and the British Society of Gastroenterology, very august bodies, produce very evidence-based guidelines. The traditional view in the older guidelines that fecal occult blood tests had no role whatsoever in assessment of the symptomatic. But these were talking about the traditional guaiac-based fecal occult blood tests, which most now consider to be obsolete in screening and in this setting. But this all changed when a couple of years ago, the National Institute for Health and Clinical Excellence actually produced a guideline on recognition and referral of suspected cancer. It's a huge document for every cancer that you've ever on the lower gastrointestinal tract. It's very detailed, it's very prescriptive regarding the age and the symptoms of the patient. Some of the things that it's stated this is primary care, should refer people using a suspected colorectal referral. That's they have to be seen within 2 weeks in secondary care if, and then it's a big list, complicated list of ages, but also tests show occurred in their feces. And the second showed who should get tests for occult blood feces, generally people who would be considered at low risk. So this, which appeared kind of out of the blue, actually caused a lot of consternation. And of course, there was considerable negativity expressed about the use of traditional tests like quiet fecal occult blood tests, but a growing realization that were it, and they were useful. And so, because of the controversy and because of all the negative feedback to NICE set up a diagnostic advisory to look at FIT in the triage of low-risk populations for suspected cancer in primary care. And this is the guidance. It's a wonderful document, very well worth reading. And NICE, this last year, said, Quantitative FIT are recommended for adoption in primary care to guide referral for suspected colorectal cancer, particularly of low-risk groups. And they said, should be reported using a threshold of 10 micrograms hemoglobin per gram of feces. And this is in marked contrast to screening grams. Some countries use 10, most countries use 20, uses 40, Netherlands uses 40, Scotland uses 80 because we have very, very little colonoscopy resource. So FIT in assessment of patients with symptoms, the cutoff point is very different from the point used in most screening programs. And if you would like to look at the evidence behind this recommendation, then there are two open, very, very interesting. What I thought I would do is just show you some of the work that we've done to support this use of FIT in the assessment of lower bowel symptoms. Because when we started this work, there was a great doubt expressed by many individuals, including many of the great and good of colorectal cancer screening. So this is the first paper that we published, and it was the first, I think, diagnostic accuracy study carried out according to the wonderful STAR guidelines. It's a very small study where we collected fecal samples from individuals who had been referred for lower gastrointestinal tract colonoscopy from primary care using one of these very, very simple, easy to use specimen collection devices. And our index test was a quantitative FIT, and the reference standard was colonoscopy with histology if required. And here are the results. It is a very small study from 739 patients. We got 280 with both FIT and full colonoscopy. And you'll see, as we expect, 2% or so had cancer, 8% had higher risk adenomas, about 10% had inflammatory bowel disease, and about the same had low risk adenoma, whereas almost 70% had other minor diseases or were normal. And you can see if you look at this ROC curve here, the ideal, of course, goes straight up here and straight along there, that as a test for inclusion of significant bowel disease, cancer, high-risk adenomas, and IBD, it doesn't appear to have a great area under the curve. We should note this, as well as in screening, people with cancer have much higher fecal hemoglobin concentrations than people with very uninteresting disease and the normal person. You can see huge differences, and those with IBD and adenoma come in the middle, and we'll see that later on. So what we thought was that using a fecal hemoglobin concentration cutoff of 10, exactly as NICE have recommended, the negative predictive value for cancer, high-risk adenomas, IBD and LRA, are all very, very, very high indeed. So if the negative predictive value is very high, then it provides a rule-out test, a good rule-out test, not a rule-in test, a good rule-out test. So it's quite different from screening, which is using FIT as a rule-in test. We were very, very heartened by this and by some work done by our very close colleagues in Spain who found the same. And we actually did the first study, I think, that was really done in primary care itself, in that we looked at fecal haemoglobin and fecal calprotectin as indicators in bowel disease in primary care. So again, a bit larger study, not too large, where 750 patients who were recruited in primary care had both colonoscopy and a FIT test result. About 40% had an undetectable fecal haemoglobin concentration. And when one looks at the traditional 2x2 table, with the 4 classes of test positive, with disease, test negative, with disease, and test positive without disease, test negative without disease, then you can see that the negative predictive value for significant colorectal disease is high. Positive predictive value is not very high. The sensitivity is getting there, so as a rule-in test, the specificity is not very good. Lots of false positives. But it's the negative predictive value that is very high, and we think that this is the most telling clinical characteristic. So, in our view, FIT in assessment of patients with symptoms is FIT is used to decide in patients of any age, not age limited, presenting in primary care with lower abdominal symptoms, identifies because of the negative predictive value those who would be unlikely to benefit from referral to secondary care for colonoscopies. So it's a rule-out test. So a negative result is probably more important than a positive result. It means there's considerable reassurance that significant bowel disease is not present, is absent. Whereas a positive result means that the patient may and probably should undergo further investigation, usually colonoscopy. So we then have started using FIT routinely as a routine test in laboratory medicine. So we distributed FIT kits with the specimen collection devices and instructions, very simple instructions which were graphical, pictorial rather than words, to all our primary care surgeries. We analysed FIT daily on the HM-JACC ARC. We reported the fecal haemoglobin concentration, the actual numbers, back to the general practitioner with signposting links for further guidance that was created mainly by gastroenterology colleagues, and we record linked them with subsequent referrals and colonoscopy reports so we could provide a newsletter, a quarterly newsletter to general practice showing how this test, FIT in assessment of the symptomatic, matured over time as it was rolled out in primary care. And certainly in Scotland, it's being rolled out across the country as we speak. So here's FIT in the symptomatic patients, and this is Judith and Becky in our laboratory in NHS Tayside. 2/3 of the referrals now are accompanied by a FIT. And going back and looking at the first year of data, almost 1,400 patients with a FIT completed colonoscopy. About half had detectable fecal haemoglobin, just as was found in the pilot studies, interestingly enough, and 5% had really very, very high levels of fecal haemoglobin. And we found in this group 279 cases of significant bowel disease, colorectal cancer, higher risk adenomas, and inflammatory bowel disease. And these are the clinical outcomes. And this looks quite complicated. But what we've done is divided the results, the fecal haemoglobin concentrations, into 3 groups. Undetectable, lower than the limit of quantitation, lower than the limit advocated by NICE. Those who had really very high concentrations, and those who had concentrations which were below the upper limit of the working range but were detectable. And you can see that in colorectal cancer, most of the cancers had very, very, very high fecal hemoglobin concentrations, and only a few had low, undetectable concentrations. And interestingly, much the same pattern is found with inflammatory bowel diseases, particularly ulcerative colitis. And then, as we would expect, higher risk adenoma are rather in the middle. But again, there are more with fecal hemoglobin concentrations detectable than there are without. And if we go to the bottom panel here, we can see those with no abnormality detected on colonoscopy. Many of them had undetectable fecal hemoglobin, whereas some did have, but few had really very, very high levels. And the similar sort of pattern was found in patients with less serious colorectal disease, although rather more of them had higher values than the people with no pathology at all. So, as we expect, fecal hemoglobin concentration is related to severity of colorectal disease, not only in screening, but in assessment of the symptomatic. So, we believe that FIT can be introduced into routine clinical practice. FIT and clinical assessment and full blood count surpass the predictive value of symptoms alone. And a recent paper, it's actually just come out in the 2018 first issue of the Annals of Clinical Biochemistry. We've combined all the Scottish pilot studies, and they certainly perform far better than NICE guideline NG12. And using this low cutoff, FIT provides an objective means of identifying patients with an extremely low risk of underlying serious bowel disease. So you can reduce referrals. Our referrals reduced in the first year by 14%. So, in addition, at colonoscopy, the yield of, as I've just shown, of bowel disease is related to the fecal hemoglobin. The higher the fecal hemoglobin, the more likely it is that there will be significant disease. Now, we talked about risk scoring earlier on in screening, and there's a great deal of interest in risk scoring. In risk scoring in the assessment of the symptomatic, there are a number of models which have been published, and this is a very, very good review of them, which shows that they all have high sensitivity for colorectal cancer. They have high areas under the ROC curves. They have much better discrimination when compared to NICE and SIGN guidelines alone, but only a few of these models at this stage include a positive FIT result in the multivariate analysis. So what we did with our colleagues in Spain and our colleagues in other parts of Scotland was we suggested that there should be a very simple score called the FAST score, the fecal hemoglobin concentration, age and sex test score. And this is the ROC curve for colorectal cancer. The derivation cohort for the FAST score to derive the algorithm was a huge Spanish study called Colon Predict. And if you're interested in the Colon Predict study, just put Joaquim Cubiela into PubMed and you will find his very interesting series of papers, including the Colon Predict study, a risk score, but a very complicated risk score in contrast to the FAST score. We have 3 variables. The Colon Predict has 11. The external validation cohorts were in Spain, Scotland and in Spain, and as you can see, it's got quite a high area under the curve for colorectal cancer. So we know that many factors influence the colorectal cancer. So when we were doing the FIT study in routine practice, we actually asked many of the people if, when they came for colonoscopy, to complete a questionnaire for us. So we've got information on symptoms, medication, family history, diet, smoking, alcohol, physical activity, hours spent sitting, their BMI and their waist circumference, and we plan to look further in the near future at various other types of risk scoring, incorporating not only fecal hemoglobin and probably age and probably sex, because these are really important, but also some of the other variables. Although fecal hemoglobin per se, as a single test, along with clinical impressions and the full blood count and so on, actually are proving very, very, very useful in the assessment of patients in primary care, as I've demonstrated to you. So, in summary, thank you very much for participating in our webinar today. I hope it's been of interest to you, and my overall conclusions are that asymptomatic population screening has now been widely introduced using FIT as the best non-invasive investigation currently available. There is no doubt that screening using FIT does reduce the burden of colorectal cancer, not only mortality, but also after repeated screening rounds, incidence since adenoma are picked up. But I think that better use of the fecal hemoglobin concentrations that we can generate using these wonderful quantitative FIT must be developed, eliminating this one cut-off fits all approach and reporting results simply as negative, come back in 2 years or 1 year, positive, go for colonoscopy. And then the second use of FIT is growing very, very rapidly and is of interest not only in England and in Scotland, but also in other countries which find their colonoscopy demands are simply unable to be dealt with, such as in South Australia. And there's firm evidence that FIT rules out most significant bowel diseases in patients presenting with lower bowel symptoms, although we don't catch them all. That was very important. There were some green bars in our significant colorectal, significant bowel disease group, and therefore safety netting, such as the general practitioner watching or waiting, or referring the patient if they think there's a problem to gastroenterology or surgical outpatients, or even doing a repeat FIT test. That is quite mandatory that we think about robust, what is called safety netting, to ensure that no one with significant colorectal disease is falsely reassured and then has a significant problem later on. So the evidence that we have generated and our colleagues have generated definitely supports the use of the NICE guideline, the new diagnostic guideline, DG30, which encourages the use of FIT in assessment of patients in primary care. And in both settings, the use of FIT might be improved through risk scoring, and certainly there are a number of groups looking at this at this particular time. So thank you very much indeed, and I look forward to your questions.
Thank you, Callum. That's an absolutely brilliant overview, or very detailed overview, covering FIT in both screening and symptomatic populations, and covering so much evidence as well. So thank you ever so much. So we have got a few questions. I'll run through them in the order in which they've appeared. So Dr. Neophytu, apologies if I've got the pronunciation wrong, has asked if you could just clarify when you mean deprived, what you're referring to. Please.
Yes, when I talk about deprived, in most other countries they would talk about socioeconomic status, which is a complex matter depending on housing and education and salaries and crime and so on. And what I mean by deprivation is really socioeconomic status. The Scottish Index of Multiple Deprivation takes all these factors into account, and it's not just diet, although diet is important, of course, and in our community at least, the more deprived people have much worse diets than the less deprived people who eat more fibre, more fruit and vegetables, don't smoke so much, don't drink so much, and so on.
Great, thanks, Callum. And then a second question from the same participant is around screening with FIT, and would you recommend using a single FIT for screening within an episode, or 2 to 3 samples within the same episode collected over different days?
Yeah, well, I think the evidence is certainly that if you collect 2 or 3 fecal samples, then the sensitivity of the test will increase. There is no doubt about that. However, the cost of doing 2 or 3 tests is more. The logistics of getting people to fill 2 or 3 specimen collection devices is quite complicated, and most publications encourage the use of one and one only FIT specimen for use in screening, particularly because most screening programs are not just doing one-off. It's not just a prevalent screen. They are repeating the FIT every year or every 2 years, depending on the resources mainly in that country. The other interesting situation is that some would suggest that rather than collecting 2 or 3 specimens, then you collect one specimen but use a lower cutoff point, a lower threshold than if that you would use with 2 or 3 specimens, giving a similar yield of cancer and higher risk adenomas.
Great, thanks, Callum. So a third question is from Katrine Raymond, I believe is from Estonia, commenting on how when the clinical outcomes, when you see a haemoglobin greater than 400, there is no abnormality detected on colonoscopy, and can you explain that? What's the reasons for that?
Yes, that's a very interesting question, which I have discussed. Obviously, our team contains gastroenterologists, endoscopists, surgeons, and so on and so forth. And there's not really a very good explanation, apart from the fact that the gut may have some inflammation, but a small amount of inflammation, such as the patients would not be classified as having IBD. But I think in general, the real honest answer is I don't know, and I don't think anyone else does either. But it's better, I think, to get false positives than false negatives, because if all positive results will go for further investigation, usually colonoscopy, and I would rather have a high FIT and a normal colonoscopy than a high FIT and serious bowel disease. So it's very reassuring for patients who do have a high FIT and a normal colonoscopy. But the explanation, I think, is obscure at this particular time. I'm sorry.
Thanks, Callum. So the next question is one that's very relevant and of great interest to both Callum and myself, I think, at the moment. And this is a question from Cheryl Tommelty, who's referring to the cutoff of 10 micrograms of haemoglobin per gram of faeces and the lot-to-lot variation that occurs with haemoglobin reagents, and how we can be sure that the precision and accuracy is as good as it should be, and how it can be improved within and among the manufacturers.
Yes, indeed. That is a very interesting and very timely question. And there's no doubt that, especially at these low concentrations that we use as cutoffs in assessment of patients with lower bowel symptoms, that the results are different. And also this is true in screening. And if you're interested in this, there's a wonderful recent paper by the Herman Brenner's group. The first author is GIES, Gies, with the initial A. And they have compared nine quantitative tests for fecal hemoglobin concentration. And they show that the manufacturers have different cutoff points. They show that even if you change the cutoff to have a standard cutoff across the 9 systems, the results are different. And they suggest other ways of comparing tests, as we have done, for screening purposes, looking at equal positivities rather than equal fecal hemoglobin cutoffs. But this question is rather different, and I would tell Cheryl that everyone is very interested in this. And so the IFCC, the International Federation of Clinical Chemistry and Laboratory Medicine, of which EFLM is a component, have set up a scientific division working group on FIT, which is chaired by Sally, in fact, and they are working very hard with tremendous input from the FIT analytical system manufacturers. And I really do mean tremendous input to look at improving standardization and harmonization of a number of really important aspects, not only analysis and analytical performance characteristics, but also very important pre-analytical performance characteristics. So it's watch this space, because Sally's group has really got this certainly in progress, and we expect to see something good coming from the group very soon.
Yeah, fingers
Perhaps
crossed.
Sally would like to comment.
Yeah, I think it is a very valid question. There is no standardization of the FIT analyzers, as Callum has said. And there are analytical challenges because of the pre-analytics and the analytical aspects. But suffice to say that all the manufacturers are very keen to improve this. So the working group is going very well, and we'll get some outcomes hopefully as soon as we can. And we'll publish those as soon as we can, or make them public. So it's a good question, very, very timely. So we do have another question. Thank you for all these really great questions. We were warned there might not be any, so it's good. So this is a question from Patrocinio Chueca. I apologise again for the pronunciation. And it's a question around the velocity of the testing, Callum. So if you talk about doing multiple samples and the velocity, the increase between sample A and sample B, for example, what should be the time between those two samples or the multiple samples?
Again, that's a fascinating question, and the answer is nobody knows. It's a postulate that personalised medicine will actually have benefits, particularly in the FIT for screening. It's sometimes called precision medicine these days. So people are very interested in looking at individuals. And you will remember that many years ago, there was particularly in the United States, know your number. You had to know what your cholesterol was. So perhaps we should transfer that to our field of interest here and say, you should know your number, know your fecal hemoglobin concentration. If it's above undetectable, then you are at risk of future incident colorectal neoplasia. And the higher it is, even though it's underneath the cutoff point applied in the particular screening program in your country, then the higher it is, the higher the risk of future disease. So knowing your number might be something, but this is for the future. Looking at personalised medicine for fecal hemoglobin concentration in colorectal cancer screening is something that I would like to see researched, and it definitely requires research at this particular time.
Great. Okay, so thank you everyone. I think oh, hang on, we have another question. So Cheryl's quite rightly pointed out here that her and I have had some contact, and I know I've had some contact with people across the world actually in terms of lots of the quality issues surrounding the analytical aspects of FIT. And I really appreciate all the input, and Callum's obviously been instrumental in getting all these things going. So our next question is from Patricia Estevy. Because of the campaign of the cancer associations, there are people who demand the GP to do the test as a screening, even though they're not of an appropriate screening age. And if this is done, should we be using the 10 micrograms per gram cutoff for patients without symptoms? And does this affect the value of the test?
Well, that again is an interesting question, because as I tried to point out, that FIT is one test used in two very, very different clinical settings with different target populations, with different cutoffs and so on. The recommendations for using FIT in colorectal cancer screening, I think, are very evidence-based. And therefore, although there is some wish to lower, in particular, the age at which screening starts, screening is very, very different. And I would certainly, if I were a general practitioner or a clinical colleague and a patient turned up and said, I want to be screened and they were out with the screening age, I certainly would not give them a FIT and expect our laboratory colleagues to give a report with a cutoff of 10. I would be very, very strongly urging the patient to look at the evidence for screening, for the age, for gender, for the test, for the cutoff, and so on, and try and make the evidence translate into the views held by the patients. But I'm sure others have different opinions.
I guess it's opening floodgates, isn't it? That's the problem. And the appropriateness of testing. So we do have another question. This is from David Seacombe in Canada, who I've also had some communication with. And David's asking, what evidence is there to support the conclusion that all blood in the lower bowel has undergone breakdown and lysis? Very interesting question. So shall I repeat that question, Callum?
Yes, I can read it. Thank you, David. That's a fairly challenging question. The evidence is rather tangential to my knowledge. Blood in the lower bowel has undergone breakdown and lysis because if frank blood is present in the faeces, for example from hemorrhoids, FIT give a negative result. It's hemoglobin and its degradation products that react with FIT. So whole blood cells, erythrocytes, do not react with FIT. There has to be lysis. So the evidence that there has been lysis comes from the FIT itself. And Graham Young, as you know, from Adelaide, the Flinders Centre for Cancer, they have done some work over many, many years, which including drinking their own blood, large quantities, and looking at what happened. And I think there is evidence, but perhaps not too much evidence to support that conclusion. Not a totally satisfactory answer, because I don't think there is a huge amount of evidence apart from tangential, such as I've mentioned.
Great, and this might have to be the final question because we're 1 minute to 6. So from Patricia Estavy, do you recommend both FIT and calprotectin for young symptomatic patients? So that's about incorporating calprotectin along with FIT.
Yes, personally, no. This is very controversial. There are a number of studies which have looked at doing calprotectin and FIT in patients with lower bowel symptoms. These are delineated in the book that I mentioned, in the chapter in the book on FIT and assessment of the symptomatic. And generally, we and our colleagues in England and other colleagues in Sweden and elsewhere have all suggested that fecal calprotectin really adds nothing to fecal haemoglobin. And there's quite a lot of evidence in the literature of inflammatory bowel diseases, the journals concerned with inflammatory bowel disease, that fecal haemoglobin is actually a very, very good test for monitoring ulcerative colitis. It's directly related to mucosal health and mucosal healing and so on. And if you made me make a statement, I would say, don't bother about calprotectin. It has lots of problems, as many problems as fecal haemoglobin, or perhaps even more. And let's look at using fecal haemoglobin, clinical data, and other test results, such as the full blood count, in the assessment of all patients with lower bowel symptoms, and don't get trapped into thinking that calprotectin should be done in the young and fecal haemoglobin in the old. I don't think there's much evidence for that, really. And as I say, the evidence in the literature comparing FIT and calprotectin seems to come down quite heavily on the FIT side, and that calprotectin does not add a considerable amount.
Brilliant. Wonderful. Thank you. Well, thank you ever so much to everyone. Thank you firstly to Callum for giving such a wonderful talk and answering so many questions so well. Thank you for such brilliant questions. I wasn't expecting that many and they were so broad ranging. And thank you to everybody for participating and dialing in. We've had 62 participants, which I think is a great number from all across the world. And thank you to Daniel for coordinating, getting Callum and I up and running with all the technology stuff. So, yeah, thank you, everyone. Bye.
Thank you very much, everyone. And thank you very much, Sally, and thank you very much, Daniel. Great afternoon.
Bye. Bye, Callum.